Yeah, Javed,
Hi, how are you?
I can see you. You good?
Very good. Long time.
Longest time. Once this COVID thing is over, we have to plan something.
Yes, yes. How's everyone?
Everyone is good.
Super.
So thanks, Javed, for agreeing to be with us today.
Of course.
And I'm going to just try to kick off this session because I'm sure it's going to be quite fascinating and there'll be a lot of questions in the end. So I will try to get moving so we can allow some times. Welcome everyone to HIC Masters of Medicine Clinical Conversations that have been going on. Professor Butler is a very good friend of mine. He's someone we've known each other for 20-something years now. Javed, we're getting old, but
yes.
So it's a great delight to have Dr. Butler join us today. For those of us in the field of cardiology, Dr. Butler is very well known and doesn't need any introduction. But for the benefit of the rest of us who may not be very familiar with his work, I'm going to give a brief introduction of Dr. Butler. There won't be enough time in an hour to do justice to his accomplishments, but I'm going to try. Professor Butler is a global leader in heart failure and is very well known in the international cardiovascular medicine community. He has published over 850 papers. Many of these papers have been instrumental in shaping the way we think about cardiology and the treatments that we give, especially for heart failure. Dr. Butler is currently the Patrick Lehan Chair in Cardiovascular Research and Professor and Chairman of the Department of Medicine at University of Mississippi Medical Center in Jackson, Mississippi. He's also Professor of Physiology and Biophysics. Prior to joining the University of Mississippi, he was Charles Gagnon Professor and Director of the Division of Cardiovascular Medicine and Co-Director of the Heart Institute at the Stony Brook University in New York. He also has previously served as Director of Heart Failure Research at the Emory University and was also Director of Heart and Heart-Lung Transplant Program at Vanderbilt University. He received his medical degree from Aga Khan University and then completed residency training at Yale University, cardiology fellowship and advanced heart failure and transplant fellowships at Vanderbilt University, and cardiac imaging fellowship at Mass General Hospital of the Harvard Medical School. He has a master's degree in public health from Harvard University, a master's in business administration from Emory University. Dr. Butler is board certified in cardiovascular medicine, advanced heart failure, and transplant medicine. His research has been in the areas of clinical trials with heart failure. He has served on numerous national committees and is very well respected internationally. He is a recipient of the Simon Dack Award of the American College of Cardiology and Time, Feeling, and Focus Award by American Heart Association, and has been cited multiple times in America's Best Doctors list. I can go on, but we have to pause here so that Javed can take us through the field of heart failure. Javed, welcome. Next time you'll be in person in Jamaica. You missed the last meeting for reasons we both know. But nevertheless, thanks to Zoom, we have the privilege of having you here. Thank you, Javed.
Great. Well, one, I very much appreciate the opportunity and I'm honored to be giving this talk. Two, this introduction was way too formal. So from here on, it's entirely informal. So please stop me in the middle of the presentation and I try not to talk for say more than 35, 40 minutes and leave plenty of time for question and answers as well. And what I thought I would do is talk about heart failure preserved ejection fraction, a little bit about sort of the philosophy and where the thought process is for the disease state, and some of the insights that I have from Emperor Preserved and where the field is going. But I will make a lot of editorial comments. I thought that would be more interesting than just going through details of all the previous trials. So I'll try to make it a little bit more opinion-based talks rather than just a rehash of what is already there in the papers. Also, in order for our time to be spent well and for it to be of value for you, I will actually show you a bunch of data which are not published yet. So they're all in review right now. So I would appreciate if you don't take tweets and tweet it out. Journal editors get upset at that. And then lastly, my disclosures are at the bottom of this slide. Okay, so with that said, just to put the sort of the epidemiology to rest, I don't think that I need to spend too much time. Everybody knows heart failure, big ticket item, global item, growing item. So lots of patients with heart failure, the number of people with heart failure continues to grow. And these people have really bad outcomes. And we are really worried about the clinical outcomes, but we are also worried about the economic outcomes because of these people continue to have recurrent hospitalizations. And then the quality of life and the morbidity business. So I'm not going to go over a lot of numbers because we all know this. Now, one issue sort of comes up is, this ejection fraction and, how do you classify patients on the basis of ejection fraction? It's a whole different debate to have whether we should classify heart failure on the basis of ejection fraction at all to begin with. And that's a separate discussion that we can have. But in terms of where we categorize this, I just really want to give a little bit of a historical perspective because there's a lot of folks that are concerned for good reason as to why do we call HFpEF greater than 40%? Why do we include 40 to 50% in clinical trials where clearly these patients have low ejection fraction? And why don't we do trials in HFpEF greater than 50%? So let's quickly deal with this issue. So remember that, in the 1980s, the only treatment we had for heart failure was digoxin and diuretics, and we had nothing more. And at that point, Jay Cohen and these other people sort of were trying to figure out how to treat heart failure. And one of the things was that they took these patients who were in the hospital in really bad shape and put a Swan-Ganz catheter in them, and they basically found, tachycardia, vasoconstriction, high SVR, and low cardiac index. So they said, we should really try vasodilators. So observational data were with IV nitroprusside, and cardiac output went up, and creatinine got better, and all that kind of stuff. And they said, well, we need to try some oral vasodilators. So that's where all of these hydralazine nitrates trials initially started as vasodilators, balanced vasodilatation, preload and afterload between the two. But the question is that you cannot do a clinical trial putting in swans in everybody to see what their hemodynamic is. So they said, well, which are the heart failure patients that are likely to have more hemodynamic abnormalities? Now, remember, this is 1980s, and we're talking about digoxin and diuretics. So this is not modern medical therapy era. And they said, the lower the ejection fraction, the worse the sort of the hemodynamics. So maybe we should just use it EF less than 35%. And there sort of began this whole era of HFrEF, and we just basically created a disease out of nowhere because we wanted a surrogate for hemodynamic abnormalities. And then some people used 40, and then other people used 40. And then even when we moved away from vasodilators to neurohormonal blockade, you wanted to compare it to vasodilators. And since those trials were 40 and 35, we did subsequently all trials with 35 and 40. Then came sort of late 1990s, ACE inhibitors are there, beta blockers are there, but we are also realizing that there's a lot of people, almost half or so, whose ejection fractions are more than 40 who develop heart failure. So what to do with them? We have no evidence. So the first trial program that said that they will look into this ejection fraction, higher ejection fraction and heart failure was the CHARM program with candesartan. And at that time, there was a big debate, and they wanted to do a trial with EF greater than 50% and call it heart failure with normal ejection fraction. The problem is that if we would have done that, we would have never had evidence between 40 to 50% and not, what to do with these people. So therefore, specifically the term was used heart failure with preserved ejection fraction and not normal ejection fraction, because they knew that 40 to 50 is not normal, and they wanted evidence on the entire group of patients. So basically, this whole division of HFrEF and HFpEF into less than 40 and more than 40 is all sort of rooted not in pathophysiology, but in history of clinical trials and how the thought process has evolved. And now, 15 years later, we sort of really have found out that 40 to 50% really acts like HFrEF, and we should be really lumping them with HFrEF and not HFpEF. And this is the new universal definition of heart failure that just came out between ESC, HFSA, and Japanese Heart Failure Society, with HFrEF less than 40, mid-range or mildly reduced 40 to 50, and HFpEF greater than 50. The problem is that this definition is relatively new. The trials are several years old, so the trials still include patients more than 40, but that's the definition. So I just thought that I'll just give a little bit of a historical background. Now, is this a big deal? So it's a big deal from every perspective. So if you look at any epidemiologic study, half of the heart failure is heart failure with preserved ejection fraction. So clearly from a epidemiologic perspective is important. And in fact, if anything, the proportion is going up. And the reason the proportion is going up, it doesn't mean that HFrEF is going away. Overall, all heart failure is going up. Overall, the absolute number of HFrEF is going up. But because the growth of HFpEF is faster than HFrEF, proportionally speaking, there is more HFpEF amongst the hospitalized patients even today. And overall, this will continue to go up. So why more proportional growth of HFpEF versus HFrEF? So the two commonest reasons that are given, one is that the cardiac structure and functional changes that occur with aging put you at risk for HFpEF, and as the population ages, there's a high risk for HFpEF. The second is that the cardiac and non-cardiac comorbidities, hypertension, obesity, diabetes, etc., are growing in the population, and they're associated with HFpEF. I honestly have never seen a single study that can tell us what proportion it is, but I suspect that a lot of it is basically increased recognition of HFpEF. And there used to be a lot of HFpEF, and we just said, oh, it's just obesity, it's just aging, not realizing that 6 months ago, a person was equally obese and was only 6 months younger and did not have these symptoms. But there is a clear bias that the number one place where heart failure gets diagnosed is in the hospital setting, because in the outpatient setting, when people come in with shortness of breath and fatigue and tiredness, we rule out, COPD, asthma, hypothyroidism, anemia, all that kind of stuff. And then we just say, it's God's will. And then a person gets eventually into pulmonary edema, and then you diagnose heart failure in the emergency room, and we don't screen enough. But as our natriuretic peptides are becoming more and more available in the outpatient setting, and our recognition or suspicion for HFpEF and the knowledge is increasing, I think that may also be partly related to this epidemic of HFpEF per se. Now, HFpEF patients have a HFrEF also, but HFpEF a little bit more, have a lot of comorbidities. And our thought process about these comorbidities have really evolved over time. So we had a very linear relationship of heart failure with preserved ejection fraction and comorbidities. So for instance, if you take, say, renal dysfunction. So we said, well, if you have heart failure, then you have passive congestion, venous congestion, nephrosarca, edema, and you have renal dysfunction, or you have forward flow problem, decreased renal perfusion, and you have renal problem. Or if you have CKD, you say, well, you have sodium and fluid avidity, and you retain sodium, you retain fluid, and you go into heart failure. So it was sort of a unidirectional, sort of a circular relationship. Well, that may be true in part, but now what we are realizing more and more is that all of these comorbidities actually have a common underlying milieu of this low-grade inflammation, oxidative stress, endothelial dysfunction that leads to multiple organ dysfunction. And these overlap of multimorbidity syndromes in patients is actually related to many of these common risk factors. So yes, it may be that heart failure causes renal failure causes heart failure, but maybe a bigger problem is that you have a systemic milieu that causes both these diseases. And if we believe in this paradigm, then it sort of lends itself to several realizations. One is that a person in their natural history may present with one disease or another. They may present with diabetes or CKD or heart failure, but you can be pretty certain that other diseases are already brewing inside, and they are about to sort of become manifest over time. And then the second thing is that this relationship also sort of explains that the same effective therapy, whether it is ACE inhibitors or MRAs or SGLT2 inhibitors, are beneficial for multiple comorbidities because they are acting at the underlying common pathophysiologic mechanisms. What about outcomes of patients with HFpEF versus HFrEF? So a lot of academic debate. If you look at observational studies, HFpEF and HFrEF patients have almost the same prognosis. If you look at clinical trials, HFpEF patients have a lot better prognosis than HFrEF. So why this difference in clinical trials versus observational studies? Well, in clinical trials, there's a lot of inclusion-exclusion criteria, and the HFpEF patients are much less representative of the real-life population than maybe the HFrEF clinical trials. And at least that's one of the explanations given. But if you go into the real world, the outcomes for these patients are pretty comparable. But where they are not comparable and very different, that their mortality rates may be pretty comparable, but the cause of mortality is remarkably different. So if you take a group of patients with HFrEF, 80% of them will die of cardiovascular disease, and 80–90% of that 80% is basically two things: sudden cardiac death and progressive pump failure. And therefore, it becomes sort of reasonably easy to reduce mortality because if you can have something that can affect progressive pump failure and sudden cardiac death, you can sort of improve mortality. The other 20% is because life happens and cancer happens and all that kind of stuff. Now, HFpEF, to begin with, about a third of the mortality to 40% is non-cardiovascular. So you have a lower proportion of cardiovascular. And cardiovascular is much more distributed. So it's not just sudden cardiac death or progressive pump failure, but you have your strokes and hemorrhages and aortic stenosis and aortic ruptures and all those kind of myocardial infarctions and stuff like that. So the proportion of common denominator outcomes are relatively less. A lot of them have pulmonary hypertension and RV failure and multiple different syndromes. So it's been a little bit more difficult to find therapies that improve survival in these patients. But clearly, quality of life and functional capacity is sort of equally perturbed between the two groups. So how do you treat patients with HFpEF? Well, you don't, right? So if you look at the American guidelines and the European guidelines, they basically say, treat congestion and treat comorbidities, because all trials in HFpEF up until recently were basically negative.
Our conference.
So all trials in HFpEF before Emperor were negative, and you basically say, treat congestion, diuresis patients, and then basically treat cardiac comorbidities, atrial fibrillation, hypertension, what have you, and treat non-cardiac comorbidities like diabetes or thyroid or whatever to go. And there is no treatment, and that's because we've done a lot of trials and none of the trials have hit their primary endpoint. Now, is that really true? So that's sort of a big debate that gets pretty interesting. So we know the results from the TOPCAT trial. This has been discussed multiple times. TOPCAT trial with spironolactone did not reach the primary endpoint. This trial enrolled about 2/3 of the patient in the Americas, so North America, South America, and about 1/3 of the patient in Russia and Georgia. If you look at patients in the Americas, they really benefited from spironolactone. If you look at the patients from Russia, Georgia, they did not. So one can say, well, the drug works in the Americas and there's regional heterogeneity. And that's sort of not a big deal because we see regional heterogeneity in a lot of different trials, different baseline characteristics, maybe genetic makeup, maybe what they eat. So regional heterogeneity is not a big deal. But what is big deal in this trial is look at the absolute outcomes of patients in Russia and Georgia. I mean, these people are like close to immortal, right? I mean, their outcomes are so good, which is just not consistent with heart failure. It's one thing to not respond to therapy. It's another thing that there is a completely different outcome profile. So that sort of led to the question whether these patients really even had heart failure. And then a lot of the investigations were done, and it turns out that these patients were not developing bump in creatinine and hyperkalemia. So they had blood samples, and they checked the blood samples for the metabolite for spironolactone called canrenoate. So they did not have canrenoate. So there's a lot of concerns that in this trial, there was a bunch of patients in other parts of the world that were included that did not have heart failure, and even after they were included, did not get therapy. So we will get the answer to this question because now there are 3 trials going on with MRAs and HFpEF, 2 with spironolactone, 1 in Sweden, 1 in Germany, and 1 is a global trial with this novel non-steroidal selective MRA finerenone going on as well. So we'll get the answer. But what was interesting in this trial was the fact that if you look at across the range of ejection fraction, this trial enrolled patients with EF greater than 45%. So from 45 to 55, this sort of mildly reduced range, the drug worked, but as the ejection fraction went up, it did not. And also, there was a sex interaction that women tended to benefit and benefited at a higher EF level, and they did not. Well, you see it in one trial, maybe it's just sort of a side thing and maybe just a subgroup analysis, you should forget about that, except that then came valsartan sacubitril in the Paragon trial, and we saw exactly the same thing. If you look at the overall trial, the primary endpoint, they did not meet their primary endpoint, but I mean, 0.059 and 0.049, I mean, to me, it's no different. I mean, it is what it is. It's for all practical purposes, you can say it was a positive trial, but it's the magnitude of benefit, right? I mean, you have 13% reduction in cardiovascular death, heart failure, hospitalization, but they had a pre-specified analysis of EF less than or greater than median, and that turned out to be 57. And at 57%, you have 22% relative risk reduction versus 0. So this whole notion that HFrEF patients act more, I mean, there's 40 to 50, 55% act more like heart failure with reduced ejection fraction now keeps getting reinforced more and more with TopCat, with ARNI. And as you know, the FDA gave the indication after Paradigm and HFrEF and Paragon with these results that valsartan sacubitril is indicated to reduce the risk of cardiovascular death and heart failure hospitalization in chronic heart failure. Benefits are most clearly evident in EF below normal, and the FDA did not define what below normal means, and they left it to the clinicians. Now, one thing that has shown benefit is the CardioMEMS trial. So we know that these patients get congested, and congestion leads to worse outcome. And in the CardioMEMS trial, at least numerically, if anything, managing pulmonary pressures and congestion in HFpEF improved outcomes considerably. So now we are in sort of 2016, 2017, we have had like 10 negative trials in HFpEF. And the question is sort of what is the pathophysiology? And if we can understand the pathophysiology, that maybe we can drive, have therapies that are positive. So there are sort of 3 philosophies out there of what HFpEF is. And I'll sort of describe those 3 to you. And I mean, I certainly don't know what the right answer is, but I have at least critique of one. So this is the most common pathophysiology of HFpEF that people talk about. And all the big players in the field, if you may, in HFpEF buy into this pathophysiology. And I am not sure I totally buy into it. So the concept here is that HFrEF is a disease of the heart, and from the heart, it goes into the body. So whatever happens, myocardial infarction, adriamycin toxicity, myocarditis, something happens that the heart function goes down, and in response to the heart function going down, you develop neurohormonal activation, and the neurohormonal activation then leads to all your hemodynamic abnormalities and pulmonary congestion and skeletal muscle problems and renal problems and all that kind of stuff. So that's the disease starts from the heart, goes outside. For HFpEF, the idea is that the disease actually starts in the body and comes inside the heart. And that is all mediated by this issue of oxidative stress and nitric oxide signaling abnormalities. So you have oxidative stress that leads to reactive oxygen species, decreased nitric oxide bioavailability, and the decreased nitric oxide bioavailability then does not lead to stimulation of soluble guanylate cyclase, and the lack of, so on this part of the curve, I don't know if you can see my arrow or not, but probably not, yeah. So the soluble guanylate cyclase then leads to decreased cGMP production and decreased PKG signaling. Because this is occurring at an endothelial level, it affects multiple organ systems. In the heart, it leads to hypertrophy. In the vasculature, it leads to aortic stiffness. In the renal, it leads to CKD. And then this pathway is eventually leads to HFpEF because of aortic stiffness and left ventricular hypertrophy, and then subsequently the pressures go up. So why am I critical of this hypothesis when sort of most of the senior people in the field believe in that? And the reason for this is that not one, not two, not three, we have attacked this system in 4 different ways, and all trials have been negative. So first we said, well, why don't we give oral nitrate replacement? So we did that in HFpEF, giving nitrates, no improvement in outcome. If anything, the exercise tolerance actually got a little worse. So we said, well, maybe it's because the oral nitrates are not bioavailable. We should put it directly into the vessel without sort of metabolism. So we should give it inhaled. So we give inhaled nitrites, did that, nothing happened. So we said, well, maybe the problem is that it's much more degradation. So rather than working at the top and giving nitric oxide donation, why don't we decrease the cGMP degradation by blocking and giving PDE5 inhibitors like sildenafil, tadalafil, something like that. So we did that study and outcomes did not get better. So we finally said, well, you know what? Forget about giving donors or stopping degradation. Why don't we just directly go to this main enzyme, soluble guanylate cyclase, and just stimulate this enzyme directly? And we did that with a drug called vericiguat that worked in HFrEF, but we tried it in HFpEF and absolutely nothing happened. So with 4 trials and 4 different targets with this pathway being negative, now, of course, this may still be the truth. I don't know. Maybe we are not giving the right dose, right number of times, but so far we have not come with any positive result. So that's one pathophysiology. The second pathophysiology of HFpEF is that there's a group of people who say, well, HFpEF is really not a disease of the heart, it's a disease of kidney. And they make some really good point. And the point here being that when you develop heart failure with reduced ejection fraction, and you have sodium and fluid retention, that is because you have neurohormonal activation. So you got your aldosterone up and your angiotensin II up and you have fluid retention and you have sodium retention. Now, I can understand if your GFR is 20, 25 and you're retaining fluid, but the average GFR of a HFpEF patient is 60. Half of them is even greater than 60. So I realize that 60 or 70 of GFR is not normal, but HFpEF patients actually don't have much neurohormonal activation. So if your GFR is 60 to 70 and you don't have neurohormonal activation, why are you retaining sodium and fluid? Why? So then the theory comes up that these patients have primary sodium avidity. And this then also goes into this whole issue about Blacks developing hypertension and heart failure at a younger age. And we know higher sodium avidity in Black patients and all that kind of stuff. So that sort of theory evolves. We know the worse the CKD, the worse the risk of developing heart failure. In chlorthalidone, you give for hypertension and you decrease incident HFpEF quite a lot. And then spironolactone, although we don't give natriuretic doses, but it's at the kidney level and you, at least in the Americas, improved outcome. And then there's all of these data with SGLT2 inhibitors that in diabetes patients, they preserve renal function. And by preserving renal function, they reduce the risk of new onset heart failure. Again, in diabetes patients, it's predominantly HFpEF. So there is a group that believes that it's renal disease. The NIH has actually funded a small sort of a 400 patient study that is looking at 3 combination diuretics. So furosemide, thiazide, and SGLT2 combination to block the nephron at multiple places as a primary modality to treat HFpEF, not just decongest, but sort of treat HFpEF to improve long-term outcomes. We'll see what happens in this study. So that leads us to the third hypothesis, and that's what I would pitch to you, that this is the one that makes the most sense to me. And that is that, you know, the cardiorenal disease is sort of a overall overlapping condition, which is related to adiposity. So even before I explain you the pathophysiology, you can say, well, if it's related to adiposity, why are all these sort of old people who are not obese and all these Asian people who are not obese developing HFpEF? So this theory is sort of doomed to begin with. Except that what's interesting is, so first of all, your sensitivity to adiposity could be different, and there may be some genetic factors. But also remember that adiposity is not equal to BMI. It's equal to the ratio of adipose tissue to lean mass. And we know, for instance, people in Asian cultures, both Southeast Asia, like India and Pakistan, or China or what have you, even for a smaller body mass index, they actually have much less lean mass than Caucasian or Black patients. So have much less lean mass and much more relative fat. And because of that, fat stores are basically a source of inflammation and source of oxidative stress, but they have two effects. One is systemic and one is local. So we know, for instance, the epicardial fat, one has constrictive effects. So there are some very interesting studies done that this large amount of epicardial fat can have compressive effect on the heart, because most of this is in the front of the heart. It compresses the RV and your septum moves, so your LV pressures go up disproportionately high and all those kind of stuff. Mayo Clinic, lots of good publications there. But most of it is actually paracrine effect. So all your adipocytokines and leptin and adiponectin and all those kind of stuff have local effects of higher incidence of atrial fibrillation and fibrosis and diastolic dysfunction with epicardial fat is known. And the same thing is with perinephric fat and renal dysfunction. But then is your sort of the subcutaneous fat, and the subcutaneous fat then leads to chronic inflammation, and chronic inflammation leads to these multiple organ dysfunction. So you have cardiac structure and functional abnormalities, you have vascular structure function abnormalities, you have systemic abnormalities, and you have renal abnormalities. And the reason why I like this model is that now we sort of know that SGLT2 inhibitors sort of work across the spectrum, and there are either animal data or human data that has shown that SGLT2 inhibitors are associated with improved cardiac structure and function. So left ventricular reverse remodeling, decreased LV mass, increased ejection fraction, diastology, fibrosis, atrial remodeling. They're associated with improved vascular structure and function, so vascular stiffness, endothelial function, etc. They're associated with improved renal function. We know that. So you have natriuresis, more sodium delivery to the juxtaglomerular apparatus, tubuloglomerular feedback, decreased intraglomerular pressures, preservation of the renal function in the long run, and you have systemic effects. So you have fatty acid oxidation, glucose oxidation, low-level ketosis, improved ATP production, autophagy. There's a whole bunch of sort of mechanisms. Now, if you sort of buy into this theory, then there are several things that become evident. One is that one can sort of understand why the same drug, because the pathophysiology is not exactly the same, but is overlapping, why the same drug could help prevent heart failure and treat heart failure with reduced ejection fraction and treat heart failure with preserved ejection fraction because of the overlapping. Remember that ACE inhibitors and beta blockers and MRAs and all of these neurohormonal blockade, the lower the EF, the higher the neurohormonal activation, the more the benefit with neurohormonal blockade. So with ACE inhibitors and beta blocker, they have more benefit when your EF is 20% than with 40%, and by the time you have 50, 55%, you don't see benefit. But when you have these SGLT2 inhibitors that are acting through mechanisms that are common to both HFrEF and HFpEF and are not related to neurohormonal activation, one can assess why the benefits will be seen. So there are two large trials done in patients with HFpEF with SGLT2 inhibitors, Emperor Preserved, which already was presented about 4 weeks ago. Emperor Reduced, Deliver with dapagliflozin will come out in the next 6 months. So these were patients EF greater than 40%, basically, clear-cut, sort of the first positive trial sort of in the history of mankind for HFpEF, highly significant p-value. The curve started separating early. The primary endpoint was cardiovascular death, heart failure, hospitalization, 21% relative risk reduction. Now, subgroup analysis in HFrEF are really boring, right? I mean, if a drug or a device works, it sort of works in everybody, you know, thin, fat, old, young, men, women, whatever. But in HFpEF, because up until now we had no positive trial, everybody had their own preferred mechanism. So some people say, well, you know, diabetes is a special correlation, this so-called diabetic cardiomyopathy. Some people say, well, it's a disease of the kidney that I mentioned. Some people will say, well, you know, it's related to sex and estrogen and hormones. So there's a lot of interest in subgroups. The bottom line is that there were no subgroup interactions which were positive. I mean, diabetes and no diabetes, just no difference. We did not find a sex interaction, which was found in both Paragon and in TopCat. CKT, GFR greater than less than 60, no difference. Baseline medical therapy. I mean, you look at it in every different way, no difference was seen. Which then brings us to this whole ejection fraction debate, which is obviously a hot debate, right? So 40 to 50, 50 to 60, 60 plus, there was about a third and a third and a third of the patient in each of these three groups. Now, if this were some completely irrelevant continuous measure, say, I don't know, serum chloride, the correct interpretation is that there is just nothing there, there is no interaction. The P trend for ejection fraction interaction was highly non-significant. It wasn't like it was 0.08, it was greater than 0.2. All 3 point estimates are to the left. Benefit was seen in all three groups. And that's how sort of the New England Journal of Medicine made us interpret also on sort of a strict statistical basis. Having said that, this is not serum chloride. This is ejection fraction. And we now have this history of nothing working over 50, 55%. And when you see this drop in point estimate and less benefit, a lot of people are questioning, is empagliflozin the same as valsartan, sacubitril, or candesartan or spironolactone, that it only works in 50, 55, and then you start sort of losing this effect. So we looked at it in quite detail, and these data that I'm showing you is not published yet. So we looked at it in a sort of a continuous measure. Now, the problem is that when you look at continuous measure at the two extremes, the confidence intervals are really wide because your number of patients are very few. And we pooled Emperor reduced and Emperor preserved together because now we have echo data on about 10,000 patients or so we can sort of put everything together. And what we are basically finding is that we found consistent benefit in men and women all the way up to ejection fraction of 65%, but then there was attenuation of benefit from 65 to 70%, and then over 70%, all of a sudden you're seeing the benefit again. Now, to me, there are two ways to interpret these data, and I really think that we should separate the clinical interpretation from the research or statistical or scientific interpretation. What do I mean by that? Well, from a research perspective, there is something going on in that very high ejection fraction group. These patients had the highest proportion of older people, women, lowest GFR, and highest proportion of atrial fibrillation. There are 4 reasons why their NT-proBNP level should be very high, and their NT-proBNP level was barely above the inclusion criteria. So that makes you think whether these patients truly had heart failure with preserved ejection fraction syndrome, maybe some patients with just atrial fibrillation got in, maybe this amyloidosis, maybe it is just a chance finding, because I cannot come up with any pathophysiologic rationale that you would have less benefit from 65 to 70, but then more benefit from 70 to 75. And maybe this is just clinical trials going crazy with subgroup analysis, and there are too many subgroup analysis, and it's just chance finding. Also, there's a 7% plus minus EF difference in interobservable variability. So if you have a patient sitting in front of you with 65% ejection fraction, they may be 58% or 72%. And remember, these are all data on populations, averages, not individual patients. So my interpretation is that let's wait for the delivered trial, let's understand more, and we really need to understand how we diagnose and label HFpEF in greater than 65% ejection fraction. But I'm equally confident that clinically, today, if I have a patient with HFpEF, I need to change my thinking. Rather than asking the question whether I should give empagliflozin, I should ask the opposite question, whether I should not give empagliflozin. And to me, the answer is that unless you have contraindication or heart failure syndrome related to a distinct secondary cause, amyloidosis, hypertrophic obstructive cardiomyopathy, something else, some other specific syndrome. Other than that, the patient should be given empagliflozin based on the data that we have today, and we'll learn more in the next 6 months. So then the secondary endpoint was total first and recurrent heart failure hospitalization, substantial improvement. Then we look at the renal endpoint. So remember that ACE inhibitors in the long run preserve renal function, but in the short term, you get a bump in the creatinine when you give ACE inhibitors. That's because of intraglomerular hemodynamics. You stop ACE inhibitor and that bump in creatinine comes down. SGLT2 inhibitor is exactly the same. You see this initial drop in eGFR, but then the GFR gets stabilized, whereas in the placebo arm, it continues to fall. So the net benefit was about 1.36 ml per minute per year. So that's quite a lot of benefit, 1.36 ml reduction in decrease in GFR over time. But then on the right, if you look at the clinical renal endpoint, like things like dialysis and transplant, you find sort of no difference. So how do you interpret that result? Well, a simple interpretation is that empagliflozin does not improve renal outcomes. That interpretation would not make any sense, and would not make sense because now we have 5 diabetes trials, 2 CKD trials, and 2 HFrEF trials. All have consistently shown renal outcome benefit with SGLT2 inhibitors. So basically what you would be saying that there is some sort of magic happens at EF of 40%, and at 39% you have renal benefit, and at 41% you don't have renal benefit. So that sort of explanation doesn't make sense. So the second endpoint is, explanation is that sure, you had a 1.36 ml per minute per year improvement in eGFR, but maybe 1.36 ml is just not good enough. Maybe the benefit should be more robust. And that sort of doesn't make sense either, because on the left of this slide, you have a meta-analysis of 47 randomized controlled trial over 60,000 patients. And what we learned is that if your renal function is preserved by about 0.75 ml per minute, so if your renal function decrease is preserved by 0.75 ml, you have a 96% probability of slowing down the progression of CKD. And here we have 1.36, almost a double. So that explanation doesn't make sense. So what explanation does make sense? And to me, what explanation makes sense is that we used a definition and we were wrong. I mean, that's sort of blatantly what I can say. So remember that cardiovascular trials don't enrich patients for renal events. So we don't, cap the GFR that only GFR of 45 or 60 can come into the trial like the CKD trials do. In fact, the median eGFR in this trial was 60, and half the patients had even more than 60. And we don't have any other renal risk criteria either. We don't say you should have albuminuria or something like that. Not only do we not enrich for renal events, on the contrary, we enrich the trials for heart failure events. So these people have a lot of heart failure hospitalizations. We require heart failure hospitalization before enrollment, and we require NT-proBNP elevation and all that kind of stuff. So these patients have recurrent hospitalizations, and the total follow-up of the trial is pretty small. So in this case, it's like 2 years. So how do you get a group of patients with GFR of 60 and have them go under dialysis and transplantation in just 2 years? That's not going to happen. That's not the natural history. If you did a 10-year study, we would find that. So you need to come up with some other endpoint, which is a surrogate for advanced renal endpoint. So people who study rare renal diseases like Alport syndrome or something like that, they say if there's a 30% reduction in eGFR during the trial, that's equal to an endpoint. And that makes sense. You can, we all will agree that if your starting GFR is 60 and in 2 years there's 40, things are really going bad for you. The problem is that 30% doesn't work in this case. And the reason why it doesn't work is because that value works for hemodynamically neutral therapies. but it doesn't work for things like ACE inhibitors or SGLT2 inhibitors that are associated with this dip in EGFR because they change intraglomerular hemodynamics. So you get this intraglomerular hemodynamic change, and then the GFR gets stabilized, so you get a lot of noise because of that. Then the purist will say, well, you should use 57%, which is equal to doubling of serum creatinine as your surrogate endpoint. The problem is using 57% that for me, it's no different than going for transplant or dialysis, because in 2 years, I'm not going to have people who have 57% reduction in EGFR. So what we ended up doing was we stayed in the middle and we said we'll use 40%. And the bottom line is that 40% reduction in EGFR did not work out for us. So we did exploratory analysis and we said, well, let's look at 50%. What happens at 50%? So basically, if you're starting with a GFR of 60, you're down to like 30. And then all of a sudden, the world makes sense. So if you look at 40%, we had about 220 events. If you look at 50%, we had only about 110 events. So almost 100 plus events was just the GFR between 40 and 50% where all the noise was. But when you take the threshold of greater than 50%, there's a 22% relative risk reduction. I know confidence intervals are wide because this is a smaller number of events, but 22% relative risk reduction consistent with all the past 7-8 trials with SGLT2 inhibitors. And to me, at least, this is all an issue of definition and not an issue of biology. So I'll speed up a little bit here because these were the big sort of points to explain in the trial. So we measured quality of life early at 12 months and latest at, early at 3 months and latest at 12 months with KCCQ. We saw the benefit right away at 12 months and at 12 weeks and all the way to 52 weeks. This is something that I'm going to present at AHA next week. So we looked at a whole lot of threshold, symptoms for physical limitations, or overall summary score that has these other things like sexual functioning and social integration and all that. We looked at the threshold of 5-point improvement, 10-point improvement, 15-point improvement, early, middle, late. No matter how you look at that, we found quality of life benefit with empagliflozin. We saw the same benefit with New York Heart Association class. People ask, how early do you see the benefit? Do you see it before 12 weeks? How late do you see it? Do you see it after 52 weeks? Well, I don't know about KCCQ because we only measured at 12 weeks and 52 weeks, but we did measure NYHA class early and late, and the benefit was seen as early as 4 weeks and as late as when we last checked at 148 weeks. All these other endpoints like, need for ICU, CCU, pressors, IV vasoactive therapies, intensification of diuretics, all of those were in favor. The benefit first accrued on day 18, so really early benefit. Not really a whole lot of change in blood pressure, only 1.2 mmHg. So again, we will use our best judgment. We cannot take average data from population and impose it on the patient, but not really. We did not have to systematically change diuretics or any other medications. Side effect profile sort of really well tolerated, no surprises, no fractures and amputations or cancers or anything. Genital myocardic infection is high with SGLT2 inhibitors. So genital hygiene, keeping the area dry and clean is to be recommended. But what I find interesting is that earlier diabetes trials, they showed genital myocardic infection, 7, 8, 9% range. Now that we have gotten used to using these drugs and giving patients the instructions, the absolute rate was only 2.2%, certainly higher than placebo, which was 0.7%, but makes a difference. And the diabetes side effects, ketoacidosis and hypoglycemia, there was just no difference between the two arms. Now, this is not to say not to worry about it, but again, the idea being that these side effects can be mitigated or completely gotten rid of by giving some patient instructions and some simple precautions. So long story short, Emperor Preserve was designed to answer these 3 questions: cardiovascular death, heart failure hospitalization, total heart failure hospitalization, and renal function preservation with EGFR slope. All 3 were met. All 3 were highly statistically significant. And if you compare Emperor Preserve with all other previous HFpEF trials, you see the substantial benefit, and we are really happy that this is the first positive trial. And if you look at Emperor Reduce and Emperor Preserve side by side, these results are superimposable and we truly have a therapy across ejection fraction, and we will learn a lot when Deliver with dapagliflozin comes out in about 6 months. So I'll stop here. I really appreciate the opportunity to have to talk to you guys, and I'm happy to answer questions.
Yeah, thank you, Javed. That's a fascinating presentation, quite exciting. A lot of things to take in. And I'm sure there's going to be a lot of questions. People would like to know more. Let me kick off the questioning by want to take you back to this issue of chronic systemic inflammation. Because I think for many years, there's been a lot of chatter about chronic systemic inflammation as being possibly one common pathway to cardiovascular disease. I understand the failures of the nitrate therapies, looking at signaling pathways and so on. I know that in the past, there have been some studies that looked at anti-inflammatory markers and possibly without much success. What is the current thinking in the field about looking specifically at, because this SGLT2 story is quite compelling, you know, that possibly that might be a pathway. What's the state of affairs in the heart failure world today, and generally in the cardiovascular disease community about looking at chronic systemic inflammation as one pathway that might account for a lot of things?
Yeah. So, you know, if you give very targeted, so the inflammation, we sort of all throw around this word, but it's not like there's just one pathway. You know, it's an incredibly complicated pathway. And the further down you go into the pathway and give very, very specific therapy, right? You know, people have given this, you know, injection in your behind with TNF alpha receptor blockers. Then they have given, you know, IL-6 related drug that was given for coronary artery disease. I forgot the name of the trial, whatever. So, I mean, all of these very, very targeted anti-inflammatory drugs, but they have not really improved the outcomes, or they've improved the outcomes really, really modestly. On the other hand, though, if you go more upstream and give relatively more sort of non-specific therapy, so you're not actually targeting a single inflammatory pathway, but you're targeting sort of things that produce inflammation, those tends to work a little bit better. Having said that, the people who really study inflammation for their lifetime, they still think that they will have more targeted therapies in the future that will be more beneficial. But if you look at statin therapy, if you look at SGLT2 inhibitor therapy, those that work on more generic upstream pathways, so far that they have been beneficial. So I don't think that there is any doubt or debate or question whether inflammation is present or is a driver of cardiovascular disease. But how to modulate inflammation, that continues to be discussed. What I also find, yeah, CANTOS, exactly. Thank you very much for bringing that up. CANTOS trial was exactly what I was thinking about. What I also find pretty fascinating is as a heart failure doctor, you really become very humble very fast, because every drug that works in heart failure was not developed for heart failure. ACE inhibitors, beta blockers, MRA, ivabradine, hydralazine nitrate, SGLT2 inhibitor, every single drug was developed for some other reason, hypertension, angina, whatever, myocardial infarction, diabetes, and we just ended up testing in heart failure and it worked. And every drug that we have developed specifically for heart failure has not worked. So, you know, so it's really humbling. But nevertheless, these drugs, everything that has worked in heart failure, ACE inhibitor, beta blocker, MRA, SGLT2 inhibitor, they are all very diffuse drugs that have multiple mechanisms of actions and not a targeted mechanism of action.
Yeah, thanks, Javed. We have several questions. I'm going to just, read out as they come and then have you respond to them. So let's start with Dr. Mezue from Harvard, who joined us here, who you met. So Dr. Kene has a question for you. Say, what is the cost burden of SGLT2 inhibitors? How can we make it more available in developing world?
Yeah, so I will twist this question and answer it in a little bit of a different way, and that is, so I don't know what is Wymeda. What's the other name for Wymeda?
Vymeda is the sacubitril valsartan.
Ah, okay.
Yeah,
So let me give you a little bit of a long answer because I actually don't know the answer. So I'll just give a long answer instead. So first of all, let's get the science right? So I practice in the state of Mississippi. It's the poorest state in United States. So cost issues are all over the place every single day. What I do worry about, however, that when we subconsciously conflate and mix science with cost, remember, cost is a time issue. I am old enough, and Ernest is old enough, that ACE inhibitors were not generic. Beta blockers were not generic. You had to give, a trade enalapril and trade carvedilol. But that changes. In 2025, dapagliflozin will be generic. I don't know what the patent life for valsartan sacubitril is, maybe 26, 27. So let's at least get the science right. What is the best case? And then on the bedside, we will make the decision. Whatever is available is available. Whatever is not available, not available. But if we indirectly start saying that you don't need 4 drugs or you need 3 drugs or whatever, you condition yourself mentally to actually believe that. And then even when the drug becomes generic, you sort of never do the right thing. So I think, to me, valsartan sacubitril, I mean, it's sort of ridiculous, and I am partly to be blamed. The ESC guidelines that came out recently, and I was the American representative on the ESC guideline, and they still give equal recommendation to valsartan sacubitril and ACE inhibitors. That makes no sense. Because valsartan sacubitril is 2 drugs. It's not 1 drug. It's like, suppose for some reason beta blockers were never available as a single drug. You can only get it with ACE inhibitor combination. It's like basically saying give ACE inhibitor beta blocker combination or ACE inhibitor is one and the same thing. It makes no sense. So to me, the right answer for HFrEF, and I would also dissociate this whole academic discussion of inter-observal variability, differences in men and women, and just make it simple. Your EF is less than 55, give 4 drugs. EF is more than 55, give empagliflozin and wait for more data. It's really as simple as that. But for HFrEF, it's valsartan sacubitril, evidence-based beta blocker, evidence-based MRA, and evidence-based SGLT2 inhibitors. So now the next question is, what about class effect? Can you give any SGLT2 inhibitor, because the cheapest one available in your area would be the easiest one to give? That question is impossible for me to answer, because as a clinician, I would want to say, go ahead and give any SGLT2 inhibitor because it looks like it's a class effect. There are 2 problems with this. One is that there are SGLT2 inhibitors that have actually never been studied for anything. Forget about that. You can say, well, empagliflozin and dapagliflozin are studied in heart failure, but ertugliflozin has been tested for, I don't know, diabetes, at least something. I was talking to some doctors in India the other day, and they have this SGLT2 inhibitor called luciogliflozin that has not been, studied in anything. So, I mean, I don't know what to say. We know that in heart failure, 3 beta blockers work, right? So carvedilol, long-acting metoprolol, bisoprolol worked, but bisoprolol and nebivolol did not when we tested them. DPP-4 inhibitors, saxagliptin, worsens heart failure outcomes. Alogliptin, going in the wrong direction, worsening heart failure outcomes, but linagliptin and sitagliptin did not. So my science answer would be that we really need to stick where the evidence is. My clinician evidence says that if you cannot do that, then just give any SGLT2 inhibitors you can give, whatever is the cheapest available. And then to Ernest's comment about, how do you bring it to the third world countries? I mean, I honestly don't know how to answer this question. These pharmaceutical companies have these vouchers and these other programs, but to the best of my knowledge, we are almost in 2022. In 2025, dapagliflozin becomes generic. You're muted, Ernest, muted.
Okay, so thank you, Javed. That's very interesting. Cost will always be an issue to contend with. Interestingly, today I had a conversation with I had a conversation with some doctors from Nigeria that called me about somebody that was just diagnosed with cardiac amyloidosis, and they're looking for what to give. Say the man read about tafamidis and say, can he get tafamidis? I say, I don't know how he can. In the US, it's $225,000 for 1 year of therapy. So diflunasil, is probably locally available, and they'll have to get that. But it's going to be a constant, problem that we have to battle with. But I agree with you, and that's the point I've always made with our colleagues: is stick with the science, stick with the evidence. Recommend what is the best option, and then look for a way to get it done. Now, let's go to the next question from Dr. Riley. Dr. Vincent Riley has asked a question, and I'm going to read out the question from Riley. Dr. Riley says, based on the hypothesis, what are some of the medications that our Afro-Caribbean patients should be on? I think you touched on that to an extent, but you can elaborate.
Yeah, so what's interesting is that we actually published this in circulation as a hypothesis. When you have less patients in a trial, you are more likely to show null results than positive results. But what I find absolutely fascinating is that Emperor-reduced and DAPA-HF had a small minority of Black patients, really small, because these were global trials, and even in the US, the proportion was pretty little. But in both trials, consistently, the benefit in African Americans was far more than the Caucasian population. So we therefore put forward this hypothesis that, we all talk about SGLT2 inhibitors as they are SGLT2 inhibitors, but remember, SGLT2 inhibitors are coupled with sodium hydrogen exchange receptor, and you block both. And by blocking sodium hydrogen exchange receptor, you both have, at the heart level, you optimize your intracellular calcium concentration because of the sodium calcium pump, and in the kidneys you have natriuresis, and that these drugs are more beneficial in African American because of the sodium hydrogen exchange receptor. So this is a hypothesis. We obviously need some sort of more study. So that's sort of one answer for SGLT2 inhibitor. The other answer is for what to do with hydralazine nitrates. So I just want to remind people that hydralazine nitrates was in not all of these drugs: valsartan, sacubitril, ACE inhibitor, MRAs, beta blocker, and SGLT2 inhibitor. All of these drugs are across the spectrum of HFrEF patients. Hydralazine nitrates, the AHF trial, was in patients with persistent advanced symptoms, class 3, class 4, despite optimal medical therapy. So hydralazine nitrate does not supplant or replace any of these standards of care. And that's why the guidelines specifically say that all patients, regardless of their race, ethnicity, gender, heritage, whatever, should get the same 4 standard therapy. But then there is more data with hydralazine nitrates if you have class 3, class 4 symptoms, not class 2 persistent.
Thank you. Dr. Felix Nunura, who is one of our cardiologists and heart failure specialist as well, has been looking at sacubitril valsartan in Afro-Caribbean patients, and he's published some papers that showed significant improvement, actually a little bit more significant than was published in the general population. And Felix has a question here, saying, is there an Afro-Caribbean phenotype for heart failure with preserved ejection fraction?
So when Ernest invites me for a 6-month sabbatical on the beach, I will answer that question, but I don't know. So I apologize. I don't know. I would assume that the Afro-Caribbean will be the same issues with obesity and with the sodium avidity or whatnot, but I honestly don't know.
All right. And so there was another question that, came much earlier from Dr. William Brown. He wants to know risk reduction for heart failure. How does Well, you can reframe this question because I'm not sure I fully understand it, because it's saying risk reduction for heart failure. How does empagliflozin compare with sacubitril valsartan?
Yeah, so that's sort of a really important practical question, right? So if you look at the American guidelines are not out yet, but the European guidelines came out last month. And what we deliberately did is, and this was a big step, and it took a lot of effort to convince our colleague, is that there is no sequencing recommendation, none. They said these are 4 drugs which are foundational therapy. Give it in any sequence you want. So it's not like give ACE inhibitor, wait for 4 weeks, up titrate, 4 weeks, up titrate, start beta blocker, give go high dose, switch ACE inhibitor to ARNI and all that. Remember that sequencing is a historical construct, not a biologic construct. A history of medicine that in 1980s, we studied ACE inhibitors and beta blockers in the 90s and so on and so forth. We also have the data that if the drug has overlapping pathways, the drugs don't work. So giving an angiotensin receptor blocker on top of ACE inhibitor, you will not get any more benefits. All you're going to get is side effects. But when you have completely parallel pathways, then the baseline therapy makes no difference. If a drug is going to work, it's going to work. So ARNIs work whether or not you're on an MRA. SGLT2 inhibitors work whether or not you're on an ARNI, because these are independent pathways. So there's no sequencing. So I cannot answer the question head to head. There are no studies of SGLT2 inhibitors and valsartan sacubitril, but the bottom line is that these are incremental benefit, and we have to give sort of all of these things, and don't worry about sequence. Everybody is different. Some people's creatinines are high and heart rate is high and heart rate is low and dizziness and all that kind of stuff. So use mix and match. But what we do know that the best option is to give guideline-directed doses. But when it is not possible to give guideline-directed doses, it is far better to give low doses of everything than high dose of something and nothing of the other. So dose is not an issue with SGLT2 inhibitors. It's just 1 dose, 10 milligrams. It's really not an issue with MRA. 25 of spironolactone is good enough. But with ACE inhibitors and beta blockers, or ARNI dose is an issue, and it wouldn't make sense to give high doses of one and not give other. You might as well give low doses of everything. But then if you can give more, certainly go up.
Okay. So Dr. Soliman has a question I'm trying to find, but I believe the question was asking about the role of pro-BNP in clinical management of these patients.
Role of BNP, zero role.
Pro-BNP. Okay.
Yeah. So remember that we use natriuretic peptides because we want to end the trial in some decent time frame. So we enrich the trials for events, but there's no biologic basis that we think that SGLT2 inhibitor will work at BNP of 300, but not at 280, but more so at 600, all that kind of stuff. So in my opinion, once you have diagnosed, now it's a different story for needing NT-proBNP for diagnosis of HFpEF. That's a different question. But for medical management, in my opinion, today, there is no need and no role.
And would you, has anybody, another aspect of the question by Dr. Soliman is a classification of this, of heart failure. Does pro-BNP have any role in classifying those who are likely to respond and those who are not likely to respond?
So, we have some signals with some drugs like vericiguat really did not show any benefit with NT-proBNP greater than 8,000. So yeah, there are some one-off reactions like that. We do know that the patient's outcomes is the best if there's a 30% relative decrease in NT-proBNP or the absolute level is less than 1,000. We don't necessarily have convincing trials. The only thing that I would say is that I wouldn't measure NT-proBNP while I'm up titrating, because if your NT-proBNP is low, that is not a reason to not up titrate. But once you have maximized therapy, checking NT-proBNP would be a good idea. And if it's still high, I might have a lower threshold for device-based therapies, or maybe giving dose even more than what is recommended or something like that. But during the initial treatment and up titration, once the diagnosis is made, we really don't have convincing evidence to keep checking it over and over again.
So in summary, NT-proBNP should not guide initiation of therapy once a clinical diagnosis is made.
Yes. If you need it for diagnosis, that's a different story.
Okay, so let me pivot back to something else, and then I'll get back to the question from Dr. Napp. In your presentation, you kind of reviewed the various complexities with looking at the various ejection fractions and who responds and who doesn't respond. But we also know that if we're looking at ejection fraction, it's just one marker of myocardial performance or contractility, it may not tell the full story. Has anybody looked at other things like left ventricular volume indices and things like left ventricular diastolic function, relaxation times, isovolumetric contraction times, and all those things to see does that further separate those patients who, even though their ejection fraction may be 65% or 25%, but their severity of diastolic dysfunction. Some may have deceleration time less than 100 milliseconds. Some may have deceleration time that's normal. Has that been looked at, to help to decide how these therapeutic responses go?
So the answer is unfortunately no. And the reason why it's no is that the outcomes trials are 4,000 or 5,000 patient global trials. And there's not a single example where we did echoes on all of those patients to correlate those measures with outcomes. Echoes are done routinely in phase 2 trials, which are, 100 patients in each arm, 3 different doses, highly underpowered. And what you do is you look at the effect of ejection fraction and LV systolic volume index and diastolic volume index and changes in natriuretic peptide at different doses to get a sense whether the drug is working or not. So there is very good evidence that reduction in LV and systolic volume index by, say, about 8 ml per meter squared gives you a pretty good chance that if a drug can do that, that it's going to potentially reduce mortality. But that's a different question. The question that you're asking is that beyond EF, can we use anything else for responder analysis based on imaging, but we don't have any large-scale echo studies done with outcome studies?
Okay. So I know we're watching time, Javed. I promise you we'll soon try to round up. I know you have a lot of things on your schedule, but thanks for giving us this much time. But I have another question from Dr. Gustavo Napp, who is one of our cardiovascular surgeons. Dr. Napp is asking, are there any differences in indication for heart transplantation? He happens to be a heart transplant surgeon. Are there any differences in indication for heart transplant between heart failure with low and preserved EF? And based on comorbidities with heart failure with preserved EF, are there any differences in outcome after heart transplantation in those patients?
Yeah, so transplant and heart failure with preserved ejection fraction is sort of an incredibly rare thing. So, people have talked about, intractable angina, and some people have even talked about not doing a heart transplant, but just doing sort of, cutting off the nerves to the heart and all that kind of stuff. And then there is, severe restrictive cardiomyopathy or complex congenital heart disease and heart failure with preserved ejection fraction, but they start becoming really niche. I actually don't know the data, but I would assume that distinctly less than 1%, not even 1%, distinctly less than 1% heart transplants are in preserved EF patients. So the data are just basically in heart failure with reduced ejection fraction only.
Okay, thanks. Let me ask another question. Unrelated, I'm going to move in a totally different topic. We have an interest in cardiac amyloidosis, and we are going to be launching a study soon with Ed Miller, and I will be doing, as a Yale and HIC study looking at V142I in the Afro-Caribbean population, and then looking at, so how do cardiac amyloid patients with heart failure respond to these therapies? Are they a different class? Looking at this GLT2 inhibitor, looking at, sacubitril valsartan, because we know their situation, their issue is a little bit different. How do they respond? Does anybody have data on that?
So I have absolutely no idea, and nobody knows because we don't phenotype amyloidosis before entry into the trial. So we try to wing it. Now, in the future, with all of these machine learning protocols for looking at ECG, and then it's criteria correlating with amyloidosis and all that kind of stuff, we may learn sort of somewhat more. I am more comfortable giving amyloidosis patients a standard heart failure therapy when they have burned out amyloidosis and low ejection fraction, because once you have low ejection fraction, you have neurohormonal activation anyways, regardless of the cause. But the true HFpEF amyloidosis, that's a completely different disease. And I think giving them therapies like valsartan, sacubitril, or empagliflozin, there is just no data to guide anything.
Well, that's a good way to try to wrap this thing up. Thank you, Javed. And thank you, everyone, for joining in. And my gratitude to Dr. Butler for giving us this much time. We've learned a lot, and now we have to apply what we've learned. Thank you.
Thank you, sir. Take care. Bye-bye.
Okay, bye.